Yes, now Dr. Omer Goktekin is professor and Memorial Hospital from Turkey. It is a Sky partnership lecture from Dr. Omer Goktekin. He is a very renowned interventional cardiologist and city specialist of Turkey and in the world as well. So may I request Dr. Omer Goktekin?
Thank you very much. First of all, I'd like to thank Bangladesh Society of Cardiovascular Intervention for inviting me. This this very good meeting. Can you hear me?
Yeah.
Yes.
Okay. Yeah. Thank you. Thank you. So I like to talk about integrate approach, and I will talk some tips and tricks in my practice. So when we talk about integrate techniques, we have basically five approach. The one is single wire technique. Sometimes we can cross the CTO with single wire, or sometimes we need to do step up and step down. Means that we can have sometimes stiffer wire or softer wire or hydrophilic wire, and we do parallel wire technique still. I like this technique a lot, and I suggest this technique to use. This is very classical technique, but not old-fashioned. It's very successful technique in my practice, at least. And we can do IVUS guided entry or re-entry. And lastly, we could use dissection re-entry technique, which basically we could do that by stingray balloon. In CTO Club, there is algorithm for CTO approach. The first of all, for all CTO, we have to do dual injection unless unless we have nice ipsilateral collateral. Otherwise, we have to do dual injection. Even we have some macro channel, even if we have some antegrade flow, we should do retrograde injection too if we have collaterals, because during the wiring, we might lose that antegrade flow through that macro channel or bridge collateral. So this is very important rule for us. We have to do dual injection during the CTO procedure. So the first we look antegrade cap. If we have tapered tap, we have a more chance for antegrade approach, and we could go to lumen. If we have blunt cap, then we could, of course, we could go to lumen, or we can go subintimal space. And what happened if we are in subintimal space? Then we should look retrograde landing zone, means distal landing zone. If it is big enough, means if it is bigger than trio, then we have great chance, for parallel wire technique. Then we should do parallel wire technique if we have a good landing zone. If we have landing zone less than trio, we should look the JCTO score. If it is less than 2, again we can try parallel wire technique, or if it is high, if it has high JCTO score, which is two or bigger, then we can go retrograde option. Of course, if we failed with parallel wire technique, we can go retrograde option after that. If we failed with retrograde option, in my practice, we go stingray technique if we failed retrogradely. This is our approach in our lab. I like to talk about choosing the wires very briefly. If we have macro channel, or if the CTO is not that old, then we can use loose tissue tracking technique, which we can use Pilot 50, Pilot 200, Fielder XT, A, R, Sion Blake, or other hydrophilic wire. If we like to go intimal plaque, then we have to use some penetrating wire like Gaia, Judo, Ultimate Pro, Miracles, Conquest Pro, or Hornet 14. If you like to go subintimal space, if you like to do star technique or stingray technique, we can do in that time we can use Fielder XT or Pilot 200 to do knuckle wire. So in my talk, I like to focus two things mostly: proximal cap penetration and wiring of the CTO and reaching the true lumen. Let's talk about the penetration of the proximal wire. I'd like to show you one RCA occlusion. The first of all, it's very important to see where is the proximal cap. To see it, we have to, use different angle. For example, in here, it looks to me it's ambiguous cap, right, from this LAO view. But if we go from the area view, it's not a ambiguous cap for anymore for me, because I know where I should go. If you know where you should go, we can't tell it's ambiguous cap. Mostly, if we say ambiguous cap, means that we don't have any idea where we should go. But here, obviously I know where is the proximal cap, and I know where is the direction. And this is bilateral injection. It's not that long. It's not that long CTO. And in this case, first we try to use Gaia, and Gaia second easily penetrate the proximal cap. Of course, we put a wire from the side to side branch to have stable position. You see the Gaia second, it easily goes in maybe 10 seconds or 15 seconds. So what I do, if the wire goes, I continue to wiring. If it stops, then I'll have some more support on, I push my microcatheter, but if it goes, I let him go. And here, of course, we have to check if we have in the true lumen. It looks very promising to me. And from the other view now, I like to see the distal from the collateral injection. And of course, after I send the wire, I have to check if I am in the true lumen, which is the case. I am in the true lumen. After that, another important rule for the CTO, we have to change this wire. This is stiff wire. This is not a routine wire. We have to change this all CTO wires to workhorse wire. For our workhorse wire is extra support wire for CTO, like BHW or Iron Man or Grand Slam, anyone. But we change it to directly, or Sion extra blue extra support is also a very nice wire, I should mention. We do 2O ballooning, and this is the final result. So you see that we have some, this will looks like disease, but it's I think that this RCA is underfilled long time. So after 6 months, we will have definitely bigger RCA. So we don't do anything to the distal RCA in this patient. We believe that it will grow. I'd like to show you another example regarding proximal penetration. This is LAD occlusion. You see that we have a very short short left main, and my guiding is direct goes to EBU guiding goes to circ. And from other view, I don't think we can call it ambiguous cap, because I might guess where is the proximal cap, and I can probe it the wire. Yes. So from other view, we have a side branch. It's also disease, but also we have occlusion. It wasn't easy to wire the LAD. Why is that? This is another injection. We have nice collateral from the ipsilateral. So I like to go to, of course, this is circ wire, and I like to go now LAD. It will be not easy because that I just went to circ directly. But what I did here, I just pulled my guiding, and I tried to go from here because the first wire hang me. I couldn't do it, but then I push my guiding. Now it's easy to wire LAD because now my guiding pointed to LAD. Anyway, so what I did here, I did send a FP wire to diagonal. I see that diagonal is not that big, but after that, of course, we have to go CTO. In this patient, I had a fine cross as a microcatheter, and I had Conquest Pro 9. Why I choose Conquest Pro 9? We can choose here Gaia Cerulite valve or Judo and other stiff wire. But I can use Conquest Pro here basically. Why? Because I believe that this is LAD, not that long CTO, and I believe that this is straight CTO. I don't think there is a kink or curve at the CTO body. So my wire went somewhere. You know, this is follows that the vessel means that I am in the intraplaque or subintimal space. Of course, I have to remove my wire and to find the now I'm in that LED proximal cap, and I could penetrate with Conquest Pro. My wire position is not that is not bad. When I do collateral, when I do injection, flow is not that good to distal, and I try to go a little gently. This is the same wire, and you know somehow if you are in the true lumen, your wire will be free. You feel it definitely. If you look like if it is look like that you are in the lumen, but your wire is not free, most probably you are in subintimal space. You have to check from the other view, and you will see it. You are in the subintimal space, not the true lumen. Of course, we had to check it, and we did. This is the final result after putting two stent in the main artery and one stent in the side branch. We did double kissing stick technique here. Diagonal will became bigger, but it's not that big, I would say. Of course, we had to treat proximal cap as well. And I'd like to share with you another proximal penetration. This is LAD occlusion again. If you look here, we have a side branch, you know, a diagonal, and after that we have a CTO. When we have a side branch at the proximal cap, most of the time hydrophilic wire will not work, right? Because our hydrophilic wire will go that side branch. So no need to spend a hydrophilic wire in that case. We should go non-hydrophilic wire if we have proximal cap side branch. You see, this is bilateral injection. We will see better now. The anatomy, very important to evaluate the anatomy if you deal with the CTO, very important. So in here, we choose ultimate miracle 3 gram. We use this wire sometimes. We used to use it more before, but these days not much. So you please look at it here, right? So miracle 3 gram always went to side branch, always, because it's also hydrophilic wire. Goes there, I pull back it. You know, I cannot even I cannot touch the proximal cap. So no need to try another 5 to 10 minutes because we have very low chance to penetrate. So we should remove, change the wire. And now I had the Conquest Pro. Why here I can I have Conquest Pro? Because I know that I have to puncture the proximal cap. I have a side branch there. So in here you see the Conquest find the proximal cap, and when I push it, it just went to the LAD, not the side branch. It's very penetrable wire. The tip is 009 and the stiffness is 9 grams. So now you see that I will check from the collateral injection. It looks to be not bad, but I feel it's not free. So it means that I am not in the lumen. Right. So I try more with this wire. In here, I see I am not in the lumen, right? I am sure now I am in the lumen. I'm not in the lumen, but I know it with the resistance of the wire anyway. So, and then I change my wire guy a second now. This is a kind of step down technique. I have stiffer wire, but it's easy to find the true lumen with the Gaia if you are in the subintimal space, and Gaia easily went to distal lumen. And of course, we have to check. Although I'm 99% I'm in the true lumen, we have to check, of course. And this is the final result after implanting 2 stent in this patient, and we protect the side branch. It's a good diagonal branch, as you see. So we can also step down technique. This is mid RCA occlusion. It's not that long, but it's long occlusion. We did dual injection. We have a curve at the distal. You see that the RCA has a curve. This is important. And in this patient, of course, we did RCA right oblique as well. And I know when I go, this is not, this is tapered cap. In this patient, we try first Gaia third with microcatheter, and please see how Gaia third will behave in this patient. You
Hello.
set Gaia third now. This is Gaia third
Cover.
because this is tapered wide
Yeah,
went
but
easily to CTO, and you know it
no,
goes.
no.
As I told you, if it goes, I just you know, continue to wiring. From the other view, let's see, where am I? In the distal, I'm in somewhere. And the proximal, I will be okay, but in the distal, my wire went in either subintima or I think it's a maybe side branch. It looks like to me side branch. I don't think it's out of the vessel. I don't think so, but it could be a side branch. I try a little bit, but since this is a Gaia third, you know, I have a curve there. This is not good wire for the that kind of curve. What I did, I had hydrophilic wire, which is 200 here. 200 pilot 200 is hydrophilic wire. Please look how it behaves. And when I go subintimal space, I have now starting to have hematoma. If I couldn't wire another 5 minutes, I will have big hematoma and I will losing the C that flow, and it will be, you know, and looks like to me CTO goes to more distal. So I had to be very careful not to go subintimal space more. And now I am in. I think I get that curve, very nice. This is nice, but you see that some contrast at that part. It's subintimal hematoma, and I was able to insert my wire to the distal, and then. Of course, we have to check always from the retrograde approach, and this is final result after stenting. The result is a big RCA, and it will be bigger with time. So difficult penetration. What we could do, we could use the double lumen catheter for double lumen for difficult penetration. I have a very good example for that. I'd like to share with you. Double lumen catheter, we have 5 of them in the market now, and all of them works very well in our practice. So you see, we have LAD occlusion again. After diagonal and septal, we have occlusion. So in here, I had a Corsair as a macrocatheter, and my wire is Concast Pro again. Why is that? Because I like to have, you know, clean and sharp penetration in this proximal cap. But you see, my wire either goes diagonal or septal. Even it sometimes touch the proximal cap. It's easily slip either diagonal or septal. This is, I think, the difficult scenario for us. We have to penetrate the proximal cap. How we do that? We can use double lumen catheter. In here, we had Twin pass catheter here, and with the Twin pass catheter, we send the Twin pass catheter over the septal wire, and then with the other lumen, we send here Concast again, and we were able to penetrate that proximal cap easily, and my wire luckily went to true lumen with this single wire. So double lumen catheter helps us a lot in this scenario. We have 2 lumen in this catheter. One is at the tip. One is monorail. One is the little proximal. That one is the over the wire. So I like parallel wire technique a lot in my practice, and I suggest all, you know, beginner colleague to use parallel wire technique, because it's helped me a lot, and I'm sure it will help them as well. This is LAD occlusion. It looks that it's very bad and ugly LAD CTO. You know, it's but if you do bilateral injection, you see it's not that that long, definitely, but it's CTO. It looks to be nice and easy case, right? We have a channel there, shouldn't be that difficult, right? But it's not the scenario. Is my wire went easily subintimal space, and this is my wire went to subintimal space now, right? So either I can try with this wire, or I can leave it here, which I do routinely if I am in the subintimal space like that. From now, this case is pieces of cake for me. Why? Because I know where should I go easily. I mean, definitely. And this is the first wire, and the second wire now. The catheter is macro catheter. I know that my uh, uh, second wire should be 1 or 2 millimeter, maybe 1 millimeter lateral side, right? So I know that now, and please look at the wire. This is Gaia second. Now in here, I know that I should go this direction. I have to have some space with the first wire. Look how is I am. I am very good position here, and I have to continue. I have a promising looking, and yes, my wire is in the, when you feel that when I am in the lumen, just my wire try to go himself, and this is we use here double lumen catheter to recross side branch. It wasn't easy. We did this with double lumen catheter, and we did here provisional technique, single stent technique for diagonal. This is the result. And now we have recross catheter. This is very good for parallel wire technique. If we need to use double lumen catheter for parallel wire, I use recross catheter anymore, because this catheter has advantage to double lumen catheter, because they have two distal hole for the second wire. This is LED CTO, and first wire was in the subintimal space. In that case, I had recross catheter. This recross catheter, it has two over the wire system. One wire just out from the tip, and the other one which will send from the proximal. It either we have two port here, exit port, one either side. Material. If this is very good to go from subintimal space to lumen. If, for example, if I out from here, if I am other side, then I change my wire position with going with the other side port. And with this, we did this case with the recross wire, and this is the final result. So another parallel wire technique I like to show. I'm very fan of the parallel wire technique, and I like to, tell everyone to use it. I don't know, some people hate this parallel wire technique, and I don't know why. It's very helpful. This is also a CTO. The first, it looks to me that I had a channel here. That's why I had a pilot 200. We could choose also XT here. But unfortunately, I couldn't find that lumen. It goes either septal and diagonal. And here again, I had stiff wire, which is Conquest Pro. My Conquest Pro went somewhere. Conquest Pro always goes somewhere. Remember, it's very sharp wire. If you push it, it will go, definitely. It will go either subintima, sometimes out of the vessel, but it will go. Rarely, if we have a calcium blockage, then maybe it's failed, but always goes somewhere. So in here, at this point, it looks to me okay, but I feel I'm not okay in my hand, right? So and you see here, I'm in the subintima at the proximal, which I don't like it. I have a big side branch. I can't lose that side branch. And in that time, please look the other way. Yes, I'm in subintima. So this is the time for parallel wire technique. Now, first, I tried to go this way, try to find a lumen, but I failed. And I tried to go to use the same entrance point. Then after that, I like to change my direction, and I could do it, and I find the lumen. I'd like to show you final pose. Yeah, this is the final. Um, I think, guys, I think I have to stop here. I have some more slides, but I think I already take my time. So I have some more slides, but maybe next time and another meeting, I'd like to share with those slides. Thank you very much for your invitation again, and I'm very happy to be here. And I like to be very happy, and I would be very happy to be in Bangladesh after COVID, of course, in physical meeting. Thank you very much.
Okay, can you
Thank
allow
you,
him
Dr.
go
Omer
to?
Goktekin. It is a very brilliant lecture, no doubt. And actually, we are very short of time, so we are not going for taking any questions right now. So I just want to move for the third lecture from my